Hi, this is Michelle Trinka. I'm presenting to you a pre-course lecture on congenital heart defects. I feel very strongly that you need to get this information, but it's a lot of information that I'm going to be partaking and giving to you. So I wanted to do it in integrity so that you can stop and start it, so when your brain turns to mush, you can come back to it as need be. I've provided you with a couple websites that work very well for giving you congenital heart defect information and explanations. I especially like the Johns Hopkins one because when you hover your mouse over the top of the picture of the defect, it shows you a normal heart. When you move the mouse away, it gets back to the other one, the defect you were talking about, and I find that a little easier to figure out as you're working through them. So, congenital heart disease. It's actually a very small percentage of the population. 0.7% of live births are pretty much the number that we'll utilize. I can't imagine that would be on a test, but that's just to give you an idea how small an amount of people that is. It is the major cause of death in the first year of life, excluding the preemies. The etiology is pretty much unknown. It's usually as the heart is developing in utero, and it's usually developed somewhere around the 8th week of life, so you don't even know you're pregnant most of the time by the time your heart is completely developed. But all it takes is one untwist or one twist in the wrong direction to come up with a congenital heart defect. There's also other factors that are associated with defects, and I've got that on a couple more subsequent slides besides this one. So some of the other non-hereditary things that you will find as other flukes that can happen, and they are very strongly associated with congenital heart defects. The three that I want to point out of all of these that we see the most often: charge, the top one, and vactural, the bottom one. Every one of the letters of that defect, of that syndrome, means something. They're a defect of some kind that the poor child's got. The other one that we see a lot of is DeGeorge syndrome, which is actually just a deletion of a piece of a chromosome. And when we see those, they're very strongly associated with specific defects. So when we have kids that come in that have a diagnosed congenital heart defect, we start looking at everything else to make sure that that's the only thing wrong with them, that they don't have all of these other delightful things. Here's a good idea of some of the things that we see on a regular basis. Now, if you notice, I just said 0.7% of live births will give you a congenital heart defect. Notice the incidence of congenital heart defects with some of these syndromes. I thought it was pretty interesting. The one that I really want you to point to, that I want you to notice, is the Down syndrome one here. Remember, 0.7% of live, but somewhere between 30 and 50%, depending on what reference you look at, will tell you that they will definitely have a congenital heart defect. So that's a huge number. Turner syndrome, which is XO, we see quite a few of those little girls. And when we talk about defects, the way we can figure out severity is how much blockage, how much problem with blood flows, what are the pressure gradients. Those kind of things are what it's all about. More of the same. I'm not going to go in and read line by line because I think you might shoot me. But the bottom line is we want them to be flowing in the right directions. Most likely they're not because something is missing, or they have an additional hole somewhere, which makes the defects more severe, less severe in acuity. One of the things that I do want you to notice, and I kind of put a little star next to it over here, and that is that blood is lazy. Blood will always follow the path of least resistance, and not just blood, but fluids in our body. They will always go from the way of high pressure to low pressure. However they're going to do it, that's what they're going to do. Always have to understand normal so you can understand abnormal. We all know that there are 4 chambers in the heart. They're supposed to be. Not all of our kids are born that way. When we look at the vena cavas, how the blood is drained back into, the deoxygenated blood's drawn back into the heart, your superior vena cava drains everything from the head and chest. So if you draw a line somewhere around the nipple line, everything above there will be drained back into the heart from the superior vena cava, everything below that from the inferior. The blood goes into the right atrium, through the tricuspid valve to the right ventricle, out the right ventricle through the pulmonary artery. These are the only arteries in the body that have blue blood. To the lungs, where it comes back then, oxygenated to the pulmonary veins. Keep in mind that these are the only veins in the body that have oxygenated blood. To the left atrium through the mitral valve, to the left ventricle through the aortic valve and out to the body. The aortic arch is where all of your head and neck vessels are, and then once you get past the aortic arch, you're going down to where the rest of the body is getting perfused. Here's a different picture in case you're more into arrows. I like to try and show it in different ways because, and I know you all took a million courses where you learned about this, but sometimes you forget what normal looks like when you start to see some of the messed up hearts that we see with our patients. So most of our defects are either holes in the wrong places, pipes in the wrong places, one-way streets going the wrong way, or my favorite, all of the above. So the way we talk about our defects is we talk about what happens to the blood flow for a good portion of them. So we have some that are going to give us increased pulmonary blood flow, which means the blood is shunting from the left side to the right side. Remember the laziness. So since it's red blood going back to the blue blood side, these kids stay pink. They don't have any problem with cyanosis. What they do have problem is extra blood going to the lungs, so you have more problems with, say, congestive heart failure. Then we're going to talk about the ones that have decreased pulmonary blood flow. So the blood is shunting blue blood to the red side. So these kids are the cyanotic, the blue kids. The obstructive lesions, where things just don't go through like they're supposed to, and then the all of the aboves. So the first thing we're going to talk about are the increased pulmonary blood flow kids. So if you've noticed, we talk in acronyms, right? Everything is alphabets. And whether you're doing pediatric cardiology or adult cardiology, you're going to find that all we talk about is alphabets. So I put the alphabets here, but don't worry, it's coming. We will talk about what each of these defects are in quite a bit of detail. So the first one I want to talk about is our patent ductus arteriosus. Now, in utero, when you're inside mom, the PDA is a good thing to have because our lungs are deflated and not much blood goes through the pulmonary system. So this is a way for blood to go directly out to the body, but a little bit trickle back to the lungs to give them a little bit of circulation. So inside mom, we really like the PDA to stay open. It's once you're born, we're hoping that that little PDA goes away very quickly. The PDA remains open because the oxygen level in utero is low. They have a lot of prostaglandins coming in from the placenta, and their pressures are very low. So all of those things keep your PDA open. One of the things they tell moms not to do is take NSAIDs, Motrin, and things like that, because NSAIDs can close the PDA. So we want to keep it open, so we're in utero, we're fine. Once we're born, the pressures are going up on the left side. We've cut off the placenta, so the prostaglandins are gone away, and their sats start to climb. So with all those things in mind, the PDA should close. Sometimes it does not. It's another picture, and I think you can see it a little bit nicer here. So because it's red blood coming back to the blue side, what's happening is you've got more blood going to the lungs than you should have, which can give your patient a little bit of overflow. Just more pictures. So what do we see? Mostly we see pulmonary congestion that you would see with congestive heart failure. You're going to get a little bit of a murmur because of that extra opening. You may, because you've got extra blood flow going to the lungs, you may find that you have very strong pulses. And as I said, congestive heart failure is the big one. So what do we do for people who have a patent PDA after they're born? First of all, we have to fine-tune them before we can even think about closing it. So the first thing we're going to do is we're going to make sure that they have all of their congestive heart failure resolved. Give them oxygen if we need it. Failure to thrive, because while they have patent PDA, they don't have a lot of tolerance for activity. Therefore, they don't eat, because how do infants exercise? They eat, they cry, they poop. That's pretty much it. So if they don't have if they have exercise what I'm trying to say. If they have intolerance of exercise, then what's going to happen? They're going to not be able to eat much. So we need to close the ductus if need be. We can try a couple things. We can start by giving them IV indomethacin. It's a pretty aggressive way to go, but in the NICU, where we see a lot of PDAs, right, because they shouldn't be born yet, they're still so premature, if we see them there, they may try to put them on some IV indomethacin, hoping that it will close the vessel. If it doesn't, we usually take them to the cath lab, where they can go in and they can put some coils in. And these coils don't look like springs, they look more like pipe cleaners. And then the little fuzzy stuff on the pipe cleaners traps blood, which then clots and clots off the PDA. Another thing that they can do is literally go in surgically, open up the area right where the PDA is, and put a clamp, almost looks like a big staple, on the area of the PDA, which closes it off. Here's a couple different looking things that we can use in the cath lab. So if they only have a PDA and it doesn't close on their own, they'll take them to the cath lab. Most of the time, these kids don't have a PDA isolated, so we usually take them to the OR because we have several things to close off. Complications, although rare, if you think about where you're cutting, right, as I said, we're just going to cut the area pretty much right even with the armpit. We'll be cutting into the chest wall and opening it up. So think about other things that are in that area. So you have your laryngeal nerve over there. Your phrenic nerve is in that area. You have chylus, so you have lymph ducts in that area. So all of these things can create a problem. As I said, these are very, very minimally invasive surgeries, so we very rarely see these complications, but on a rare occasion we may. The next defect I want to talk about is the atrial septal defect. So this is a hole between the two atriums. There's supposed to be a hole inside mom called your patent foramen ovale. And it's supposed to be there, and then once you're born and you take your first breath, that's a one-way door that slams shut and never reopens. But unfortunately, sometimes that one stays open, or there's other areas that can have an opening. For our purposes, outside of the land of cardiac, it's an ASD. We don't care where the hole is. We don't care what the name of the ASD is. It's a hole in the atrial septal wall. Period, the end. So once we have this hole, sooner or later we have to fix it, correct? So again, are you starting to see a common theme? All of the defects that give us increased pulmonary blood flow will have similar signs and symptoms. They all have murmurs. This one will give you a wide split S2 because since there's so much more blood going back to the right side, the tricuspid valve and the mitral valve aren't going to close at the same time. Again, poor feeding, failure to thrive. So with that will come irritability. So their heart is fast, their breathing is fast. Because remember what I said, their myocardium doesn't increase squeeze because it's immature when their cardiac output is down. So the way they get around that is they give you tachycardia. The tachypnea happens because of the CHF. So what do we do for an ASD? If that is the only defect they have, we will let them feed and grow. We'll let them go until the age of right before they start kindergarten. And if it doesn't close by then, they will most likely bring them in and close them. Depending on the size of the hole, they can close it with some sort of a device in the cath lab. Or if the hole is very big, then they will have to take them to the OR and close it with some sort of a patch. Here's a little picture of a graft, of a patch that you might see on an ASD closure. So once again, here's the different ways of looking at it. The bottom line is we want to close the hole between the atriums. By hook or by crook, we have to close it. Here's pictures of some of the different devices. I just think it's kind of cool to think that these things look huge, but if you think about the size of these hearts, right? Your heart is the size of your fist. We've talked about this before. So if your fist is the size of an olive, these devices are probably less than a half an inch in size. So needless to say, the objects may appear larger than actually seen. Post-op complications. So now if we had to actually go in and close that hole, which means we have cut into the atrial wall. So what's important about what's going on in the atrial wall? Well, the SA electrical conduction to the AV node is in the atriums. So what we may see, we might see some heart block going on. We might not have closed it all the way, and we might have a little bit of a leak. Because we have interrupted the electrical conduction system, we could have some dysrhythmias. Anemia just because of the surgical procedure. AV valve regurgitation. If that hole in the atriums was low enough down that it was near the valve. There's something called post-pericardotomy syndrome that they can have, which is very rare, and I really don't want to go into it, but if you should later on become a cardiac nurse, you can go back and look it up. If somebody really wants to know, give me a call. I'll be happy to explain it. The next defect along the increased pulmonary blood flow line is to have a hole between the ventricles. So a ventricular septal defect. So the only hole in place is between the ventricles right there. I think this is a little bit bigger VSD because unfortunately a VSD in you and a VSD in somebody next to you and a VSD in me, we all might have the exact same diagnosis, but our hole might be different sizes, which is going to give us different symptoms. Now remember when we were talking about the hole in the atrium, we said that they would leave that until they get to kindergarten age and see if it's going to close on its own. Unfortunately, down here, we cannot do the same thing because it's so close to the pulmonary artery and it gives us so much more of a blood flow up there that the body can actually start to develop permanent vascular changes due to the high amount of blood flow and pressures going to the lungs. So permanent changes can occur that we can't undo. Remember the word permanent means can't undo. So we are not going to let this child get that old before we fix the VSD. These kids will have their VSD fixed probably by the age of 6 months. Just other ways of looking at it. So if the VSD is small, they might be completely asymptomatic, but if it's larger, again, here we have our reoccurring theme, CHF, pulmonary edema. Every time we have something that increases pulmonary blood flow, one of our biggest side effects is going to be increased pulmonary blood flow. And I mentioned the long-term permanent effects, which will cause pulmonary artery hypertension. And if the vascular changes do occur, Dr. Eisenmenger decided to take credit for the vascular changes. He identified them first, so Eisenmenger syndrome is what we call it. Once again, before we can fix it, we have to fix the symptoms that are coming up. So if they're in congestive failure, we have to give them some Lasix, perhaps some DIG, do whatever it's going to take to get rid of all their other symptoms. And then we're going to take them to the OR or to the cath lab. So what this first surgical procedure is, they literally put a band, like a rubber band, on the pulmonary artery. They can do this in the cath lab, and they can do it without putting them on a heart-lung machine. If they do this, it will buy them some time. Because now that we've banded the pulmonary artery, so we're saying, okay, we're forcing it so that the blood, let me go back and show you. So on this picture here, if we band this here and make this narrower, the blood that was lazy and trying to go up there, won't be able to because of the narrowing. So blood is lazy, but if it's too hard to get this way, it is going to go to the other side. So what will happen if the blue blood, is going to the red side? We've changed our type of a defect, haven't we? Not a type of defect, but we've changed. We're no longer going to be a pink kid. We're going to start to be a blue kid because we have blue blood going to that side if we put a PA band here. If they decide not to do that, but to just go in and close that hole off, then that won't be an issue with these kids. They'll just go in and close that off. Period, the end. Post-op complications, again, think about what we cut into. Since we have decreased, if they weren't banded and they just went and had the VSD closed, the body had been used to a large amount of blood flow going directly to the lungs, and now the blood flow has trickled down to a normal level. So the body doesn't understand that, and you may end up with hypertension as it's trying to acclimate to the decrease in flow going to the lungs. We could have damage to the aortic valve if that VSD was high enough right by the aortic valve area. So when we closed it, it kind of pulled the valve a little bit off. Heart block, because we're cutting into the ventricle. The PAH I kind of mentioned. And we could have a little bit of a leak left because they didn't close the defect all the way down. The last of the increased pulmonary blood flow defects that we're going to talk about is an AV canal, an atrioventricular canal. It's actually pretty much a 3 defect in one kind of a thing. So when you have somebody with an AV canal, we already mentioned that these are the Downs kids, we are going to have a VSD, we're going to have an ASD, and depending on the severity of the AV canal, we either have one huge valve between the atriums and the ventricles, or we may have small pieces of not 100% functioning valves. So here's somebody who has like a minor version of an AV canal, big ASD, a VSD, but their valves are probably halfway decent. This is what they call a complete AV canal, the one on the right. If you notice that they have one huge valve, pretty much a big ventricle and a big atrium. This one, the complete AV canal, is definitely more difficult to repair than it would be if they had something like this over on the right side. Excuse me, on the left side. Signs and symptoms pre-op, same as all the other ones. We're going and having an increased amount of blood go into the lungs. CHF is our name game. Pulmonary artery hypertension, because we have so much blood going back to the pulmonary artery, because again, lazy blood, it's going to go this way. So we have so much blood going to the pulmonary arteries, we can have pulmonary artery hypertension. So again, we're going to treat it by getting rid of all of our pre-op symptoms of our CHF. Then we're going to take them to the OR. We have to close up the hole between the atriums, close the hole between the ventricles, and somehow or other, with that big, ugly valve, create a non-leaky mitral valve and not as much worrisome on the tricuspid side. The reason that there are no artificial valves for infants. The valve story doesn't start till you've got an adult-sized heart. So when you've got an infant, you're going to have to work with this. So that's where the skill of the surgeon becomes so important. And the better they are at doing these valves, the better off your patient is going to be when it comes to having a non-leaky, competent mitral valve. Postoperatively, some of that valve problem is going to be there. I have a friend who has a Down syndrome girl who had an AV canal, and her daughter is now somewhere around 18, and she has come back in for several revisions on her mitral valve over the years because it just doesn't work very well. But the problem is, if we should put an artificial valve in her, even though she is of age and her heart is big enough to take an artificial valve, the problem with artificial valves are you have to be on blood thinners for the rest of your life. Her daughter also has Down syndrome. Down syndrome kids are not known for being very agile. They're actually known for being a little on the clumsier side. So think about putting blood thinners in somebody who falls down. What's their chances of them having hematoma in the brain, huge bruising somewhere else? So for that reason, they try and keep them away from artificial valves if they possibly can, if they have Down syndrome. So once we have done the post-op care, actually this is talking about the surgery itself, where they're going to go in. Now it says they're deep hypothermic circulatory arrest. What deep hypothermia circulatory arrest means is we're going to chill this child down to the 60-degree Fahrenheit point, so that they really don't need a lot of blood supply anywhere, and then we turn the bypass machine off. So for all legal purposes, this child is legally dead. There is no blood going in their body, their brain is not getting perfused, their heart is not beating, because in order to do all of the intricate work that they need to do, the surgeon needs a completely bloodless field, so they do this with no circulation to the body. So once they go into the full circulatory arrest, it becomes a ticking time bomb, because you can only do this for so long before you start having brain issues. So again, the skill of the surgeon is what makes these surgeries. So if you're taking care of a postoperative AV canal, the things that you're going to have to worry about are going to be pulmonary artery hypertension is one of the biggies, because we've now fixed the amount of blood supply that is going to the lungs, which had been accustomed to much higher flows, much higher pressures. Low cardiac output syndrome is a problem because we've done a lot of cutting in the ventricles, and they're kind of stunned, and they don't do very good contractility for sometimes as much as 2 or 3 days. So that can be a problem. And we already talked about the mitral valve problem. Respiratory failure is simply because of all the other things that we've just listed. So that's the end of our increased pulmonary blood flow grouping. So now we're going to go on and talk about the defects that have a decreased pulmonary blood flow. So these are the blue babies. These are the ones that, because there's some problem going on the right side, blood does go from the right to the left, making the kid cyanotic. The first one that I'm going to talk about is the most famous of all of the defects. Back in the dark ages when I was in nursing school, this was the only defect I truly learned about, because it was one of the only ones that survived, because back in the day we didn't have infant heart-lung machines, so all we had were the kids that survived were kids who could survive without surgery. Tetralogy of Fallot is a procedure, is a defect that can survive with just a small surgical procedure if need be. Tetralogy means 4. So there are 4 defects with these kids. If you are going to remember any defect for NCLEX purposes, this is the one you want to know. I'm telling you, because maybe it's because all the people who write NCLEX questions are older than dirt like I am. We all know the TET. So Tetralogy of Fallot is the one that people will ask questions about. So there are 4 defects, as I just said, involved in this congenital defect. The 4 defects include a pulmonary stenosis. So it's number 1 here. So it's a very narrowed opening to the pulmonary arteries. They have a VSD, a hole between the ventricles. The aorta sits right on that hole that's opened. So it's kind of sitting right between the right and the left, not really knowing which way it wants to go. So that's why it's called overriding. It's like sitting on the fence post. I don't know if I should be on the right side or the left side, so I'll just sit in the middle. And then the last thing, because even in utero, the heart has had to work harder, the last thing we're going to see here is the thickened right ventricle, better known as hypertrophy of the right ventricular wall. So it's nice and thick because it's been working harder even in utero. Different picture, same defect. Here's your overriding aorta, your VSD. You've got your little bit narrowed here. And your ventricle is a little thicker than it usually is. So these are the kids that they talk about having a hypercyanotic spell, a TET spell, before they have their surgery. Because they live with SATs in the low side, clubbing of the fingers, which is what you see here in the bottom of the page, is not uncommon to see. So what happens with these kids, let's go back to our picture. So here I've got a kid who's already got blue blood going out to the body, right? So instead of having normal SATs, 94 to 99, these kids may sit at a SAT of 90. And then something gets them going. Either, they have an IV started on them, mom leaves the room and they're all upset. It can be anything and everything. They fall, trip, and bump their head. Whatever it is that gets them upset. As they get upset, this pulmonary artery, which is already narrowed, will narrow even further with the stress, which means more blood from the right side will shunt to the left side, which will drop their SATs more. So what happens is you have more blue blood, decreased SATs, which give the patient acidosis, because we're now doing anaerobic metabolism. Think back to your days where you learned about Krebs cycle, right? Anaerobic metabolism. So they're going to have the anaerobic metabolism. The side effect of that is lactic acid, which makes them more acidotic. So we've not only got the hypoxia making them acidotic, we have acidosis going and getting more acid and more acid produced. So what does acidosis do? Your low pH? It makes them vasoconstrict, which in turn is going to make them even more bluer. So it becomes a cycle that they just keep going down the hill, down the hill, down the hill. So if we don't intervene with these kids, they will code and die. So one of the things that we will do, if they're babies, we will do it for them. It's called a knee chest position, where we literally bend their knees and put their knees to their chest. If they're toddlers or older and they would still have this, I've seen this when I've gone on mission trip to a third world country where these kids are older and they start to get blue, they will squat. Because if you think about it, whether you're doing a knee to chest movement or they're squatting, what it's doing is it's decreasing or slowing down the amount of blood that's coming back to the right side of the heart. The hope is that if it's coming back to the right side of the heart slower, then it will stop the ever-increasing acidosis, ever-increasing hypoxia. Another thing to know about these kids is that because they have that right ventricular hypertrophy, their heart will actually look a little bit like a boot. See how it's kind of comes out and has a definite spin to it where it's coming outward on this side more? So you may hear somebody say something about a boot-shaped heart. So if they're having a lot of TET spells, they don't like to do this repair on a newborn. They like them to be as close to a year old as they can make them. So they may do the temporary repair that was done in the 50s and 60s and 70s before the heart-lung machine was available for infants. So the temporary repair that we're talking about was named after Dr. Blalock, who was an open-heart surgeon, and Dr. Taussig, who was a pediatric cardiologist. And what they did was, plain and simple, they created a permanent patent ductus arteriosus. They put a piece of tubing between the subclavian artery and the pulmonary artery so that when they started having issues, more blood would go back to the pulmonary arteries. So a defect that would normally have decreased pulmonary blood flow, thanks to the BT shunt, will equalize out and have more blood going to the pulmonary arteries than it used to. So back in the 50s, 60s, and 70s, this was it. This was all you had done if you had a Tetralogy of Fallot. A BT shunt was put on there, and that's how they lived for the rest of their life. Fortunately, in today's world, we can do a full surgical repair. So that is what they'll do somewhere, as I said, as close to 9 months, 10 months as they can get. So what they'll do is they will close off the VSD, push the aorta back over on that side and maybe take a piece of homograft tissue to widen this pulmonary artery up so that the problem goes away. Once again, you can see the mortality is very small. Most of our defects, the mortality is between 1 to 5%, and this one is no different. So if we have a kid preoperative who's having TET spells, yes, we'll do the kneaded chest or they'll be squatting on their own, but we usually will give them propranolol, which I'm sure you remember is a beta blocker, which will usually decrease the amount of hypercyanotic spells these kids have. I talked about the palliative, the short-term fix of the BT shunt, and I also talked about the surgical repair. Here's pictures of just the BT shunt on the left and the complete repair on the right. Postoperative, again, think about where we cut. We cut into the ventricle, we have to worry about all different kinds of arrhythmias, bundle branch block and heart blocks. We have to worry that there might be a leak at the VSD, or there could be a problem with the pulmonary stenosis, that it might still be there. The right ventricle might not be used to working with this amount of blood flow, and you could have some issues there with some extra ventricular beats. Pulmonary insufficiency, if that opening was not wide enough, and the aortic valve, as they pushed it back over to the left side, could be a problem. The second type of defect that will decrease pulmonary blood flow is a tricuspid atresia. Tricuspid is the valve between the right atrium and right ventricle. So either it will be very narrowed or it won't be able to be used at all. So either way you look at it, an expression that we use frequently in the land of congenital heart defects is the phrase, no flow, no grow. So if we have in utero a defect where the blood can't get from the right atrium to the right ventricle, what's going to end up happening? Our right ventricle is going to be very small. Now in this drawing, the right ventricle still has some decent size because of the VSD. You can also have tricuspid atresia without a VSD. Here's another one with a VSD. I'm not sure I have a drawing without it. Nope, it doesn't appear that I do. Actually, I think this one is over here on the left. If you notice, the right atrium can't get to the right ventricle, so it's going through that PFO, that patent foramen ovale, that one-way door that flaps shut on birth. It's not going to flap shut on these kids because the pressure is going to force it to stay open. So all the blood goes, whether it's coming back from the lungs or it's coming back from the body, all the blood is going to go to the left atrium and out to the body. And only if they have this BT shunt will they be able to have any blood going to the lungs. So it's a pretty bad kind of a thing. And since the right ventricle had the no flow, no grow, they're going to call these kids hypoplastic right hearts. Hypoplastic means very small, and it's the right side. And so pretty much that's another way. So a tricuspid atresia could also be called hypoplastic right heart syndrome. We can't go to a ventricle store and say, I need a new right ventricle because my patient doesn't have one. So what they have to do is they are going to do some palliative work around this, and through a series of surgeries, they will palliate the child so that they can live with one ventricle. Now, fortunately for these children, the one ventricle that's there is the left ventricle. You can live, quite frankly, without a right side of your heart. The only side you truly need is the left side, because that's the side that powers the blood out to the rest of the body. So the BT shunt would be the first repair, a Glenn would be the second repair, and a Fontan would be the third. We'll talk about these again when I talk about the left hypoplastic hearts in a little bit. Signs and symptoms preoperative: if you have a lot of blood mixing, where the blue is going to the red side, your sats are going to be lower. So again, we're going to have clubbing. We're going to have lower sats, so they might be short of breath. They may have some dysrhythmias, simply because the heart really doesn't like to be in the situation that it's in. So as all the others, preoperatively, we've got to stabilize them out. So one of the things we're going to do for these kids is we want that PDA to stay open till we go in and give them that BT shunt, which is a permanent PDA. So what we're going to do is we're going to give them the prostaglandins. We can give them fake prostaglandins that are just like the prostaglandins that were coming from the placenta. So if we give them prostaglandins in the pre-op period, it'll maintain that PDA open. Once they go to the OR and they get the BT shunt put in, we can turn off the prostaglandins at that point. They'll come back in a few months for the bidirectional Glen, and they'll come back in 2 or 3 or 4 years for the final part, which is the Fontan. So on the left is a kid who's got the BT shunt. And on the right, here is a kid who's had the Glen done. Postoperative complications. Again, there's going to be 2 different types. First of all, the ones that go along with what muscle did we cut into? We're cutting into the ventricle, so we may very well see some ventricular skipped beats, arrhythmias. Since the flow, remember we said blood was lazy, and I also mentioned other fluids are. When we first, let me go back to the picture. When we first sew that superior vena cava directly to the pulmonary artery is getting more blood than it has ever gotten before, and it's not tolerating it very well at the beginning. So what ends up happening is the blood, instead of going in, the blood's going in, but the amount of fluid is not. So what's happening is the blood starts to seep out into the tissue, and you also have some venous congestion happening. So a lot of times in the immediate post-op period, they'll call the kids Glen heads, because post-op Glens have a lot of swelling from the nipple line up, right, the superior vena cava. So they'll have like venous stasis, so they'll have that ruddy color, and they'll have swelling. Within 48 to 72 hours, all of this disappears as the body acclimates to the higher pressures, and they'll do fine. I'm just making sure. Protein-losing enteropathy is another issue they could have. If you have a lot of extra fluid going to other areas, one of the areas that it's going to go to is into the pleural sac. So in the area between the lung and the sac, fluid can collect there and develop pleural effusions. Well, the type of fluid that you're draining from that area is yellow, and yellow means we're losing protein. So instead of maintaining their protein in their body and using it for growing as they need to, the protein is being lost into the fluid, into the pleural sac, into the peritoneal cavity, so they end up losing protein. And since it's so important that these kids go home and grow so that they can come back for their 3rd surgery, and sometimes the Fontan happens and then they get the protein-losing enteropathy. But these kids will have problems maintaining growth through their whole childhood. When you look at these kids on the growth charts, a post-op Norwood, which is the first, let's not even go there. After they have their Glen, the chances that they're on the growth chart somewhere around a 10 percentile is very high. Their chances of having a 10 percentile height and weight, simply because they don't have good perfusion, so they don't grow, and because all of the calories that they're eating, a lot of that's being burned up in just living, because they're not used to being, the heart does not tolerate this defect very well for very long. Here's another picture of it. So here's a good picture when there is no VSD. So if you notice, this time round, the problem, instead of being a tricuspid atresia, is a pulmonary atresia. So the atresia was at the pulmonary valve. And I think it's a really good indicator. Look at the size of that pulmonary artery. It's scrawny, 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 going back to the no flow, no grow. At this point, we're going to go on to the next group of defects called obstructive lesions. So these are lesions, and actually, I apologize, but the slide from the previous that I just looked at, the pulmonary valve stenosis, is actually under the obstructive lesions. Somehow or other, it's snuck up ahead of this slide. But with the obstructives, it's when we have valves that are either very narrow and very poorly, maybe rigid, so very little blood can go through, or they're not patent at all. They're not open at all. Another one that we're going to talk about that goes along with the same thing, obstructive lesion, is something called a coarctation of the aorta. So your aorta, right, when you hit the aortic arch, it should be very nice and fat all the way down. But there are some kids who have a narrowing, and it's usually right here. And I don't know if you can remember back to previous defects that we've already talked about in the last half hour or so, but there was one called a PDA, right? It was the first one we talked about. The PDA is actually right here. Before it closes, this is where it would be. So if there's a coarc, it usually happens right around the same spot. So you're thinking, okay, it's a narrowing. Well, we can do good things there. We could probably put one of those stents like they do for the adult MI patients, right? We can stent that thing open, and that'll be the end of that. Well, it sounds like a great idea, but one of the problems is when we talk about stents, children continue to grow. Metal stents don't. So this cannot be repaired with something that doesn't grow with a child. So what ends up happening is we can try and go to the cath lab and blow a balloon up in here and dilate it and hope for the best. But usually what we will see is that being done for the best isn't the best. They end up having to go back in and do some sort of a surgical repair there because it just doesn't stay open when they use the balloon on that. So what they do is we have to figure out something to keep this area open wider. Another defect along the same lines as the coarctation of the aorta is the interruption of the aortic arch. So over here on the left is a normal aortic arch, and over here on the right is literally the aortic arch just kind of stops, and it doesn't go out to the body with it where it should. As you can see, it does here over on the normal side on the left side. Mentioned the stents, thought I'd show you what they look like. If they put a stent in a child, it doesn't grow, so as the child grows, what is helpful to a child today might be lethal to a child in 6 months to a year because it doesn't grow. So we always know that if a stent is put in a child, they will be coming back to either the OR or the cath lab to have that stent removed and something else done. But if a child's born very, very premature or very small and they're really worried about having them tolerate surgery, the stent will buy us a few months until they're a little bigger and could tolerate the procedure better. Whether it's a coarc or an interrupted aortic arch, their symptoms are going to be very similar. Since the blood can't get through the coarctation or the interruption of the aortic arch, it's going to back up. When it backs up, we're going to end up with congestive heart failure. Since the blood is not getting out to the body because of the narrowings, we're going to have decreased cardiac output. The blood is staying on the right side of the heart, but it's not getting out to the body. So there won't be any blueness because there's no blue to the red side. It's all red to the blue side. Since both of these things will give circulation to the area of the head and neck, but not the lower extremities, this is something that we can diagnose ourselves as nurses. If we do a blood pressure on all 4 extremities and we notice the arms are about 20 millimeters of mercury higher than the legs, that's a real good indicator that something's rotten and this coarc or this interrupted aortic arch is here and doing evil things. Just like all the others, we're going to start by stabilizing them out before we can take them to the OR. So if they go and they take them to the OR as a coarc, they don't need the heart-lung machine. They can actually do the surgery just from the outside. So they literally will go in and put in a little bit of a patch that will widen the narrowed area and be done with it. They will do that for both the interrupted aortic arch and for the coarc. As I had said earlier, they can try going to the cath lab and try balloons or whatever, but that's only for the coarc, because the interrupted aortic arch has to have some sort of a patch because it's completely interrupted and not connected. So for that surgery, we're just going to go in and put something that will connect the aorta back to the descending aorta. So with a coarc, here's an attempt with a balloon, but here's the surgery where they actually went in, cut out the narrowing, and sewed the two wide pieces together. The interrupted aortic arch, the same kind of a thing. We're going to put an anastomosis in here so that the aortic arch, the blood can go very quickly and without issue from the head neck vessels down into the inferior aortic arch, the descending aortic arch. So postoperatively, since we've been messing with the aorta, if you'll recall, on your aorta are things called carotid bodies. Carotid bodies, when stimulated, will create renin, which is one of the most potent vasoconstrictors our body makes. So when you have coarcs and interrupted aortic arch surgical repairs, you have to worry about severe hypertension in the post-op period. They may very well go home on antihypertensives and be monitored closely, and after somewhere between 2 weeks to 2 months, they'll be able to wean off all of the hypertensives and they'll be back to normal. Another problem you have to worry about is this mesenteric arteritis. If the body below the nipple line has not been getting good perfusion since the day they were conceived, they're not getting good perfusion to their gut either. Their intestines are not getting good perfusion. So now we've fixed the repair, and the mesenteric arteries are getting full blood supply, which they've never gotten before. So if we try and feed them too quickly, where they're getting a demand for a blood supply, that can create a major problem. They can end up with arteritis and inflammation to the arteries of the gut, and they can actually end up with dead bowel, just because we fed them too aggressively when they first had the surgery. Paralysis isn't also a possibility. I have never heard anybody have that issue in the 20 years that I've been taking care of these kids, but it is a possibility. The mesenteric arteritis is something that I have seen a couple times, but again, very infrequently. The next stenosis I want to talk about is your aortic stenosis. So down here at your aortic valve, it's not working very well. So the blood can't get out, so what's happening here? Remember what we said, no flow, no grow. So it will continue along this path. So what might happen is, since it can't go any further and it's backing up, we could have issues with our left ventricle, but most likely it's just backing up from the left atrium back to the lungs. So again, we're going to have pulmonary congestion, congestive heart failure, and since the blood can't get out to the body, we're going to have problems with low cardiac output, hypotension, and just poor perfusion to the extremities. Different types of stenosis, I don't think you really care. If you go into craziness in the land of cardiac, all of this will become very important to you, but for right now, aortic stenosis is aortic stenosis. That's what you need to know. So what we have to do is we have to fix this, right? So once we have it and no blood is going out to the body, we have to figure out how we're going to do it. We can try going in there and breaking open the valve. We can try and go in there and go with a balloon. Neither one necessarily is going to do what it needs to do. Balloon, again, can work for a short time, and then the next thing you know, you have aortic insufficiency, the valve has had a tear and is not working right, or because they go in through the groin, they may end up with decreased pulses to that groin that they went into and having poor perfusion. There's different areas, as we mentioned before, that aortic stenosis happens. Depending on where it is going to depend on the repair work that we are going to do for these kids. There's a Ross, there's a Kono, named after, of course, Doctors Ross and Kono. The bottom line is what they would do with these kids, because again, there's no valve store for newborns. So what they will do for the interim is, since the pulmonary valve works fine, the aortic valve doesn't, what they will do is they will cut the aortic valve out that's no good and throw it away. They'll go over to the right side, cut out the tricuspid, so the tricuspid to the bad area and where the aortic valve was, and either put no valve where the tricuspid valve was or put some sort of a pig valve there. And the kid will survive for quite a long time this way. What we will see them do is it gets them through puberty and it gets them through high school and possibly even college before that tricuspid valve fails, because it's not meant to be a high pressure valve. But the plus is it got the kid through everything he needed to do as a child. Usually by the time they're 18, they're not doing a lot of contact sports anyways, so it's not that important that we now replace the defective tricuspid valve that's in the aortic spot with a fake valve. Remember I said fake valves require blood thinners for the rest of their life. Well, they've made it through puberty. They're now an adult. They can handle it. So that's where the Ross-Kono surgical procedures become very helpful. Lots of different pictures of the procedure. Okay, we're on to the big ones, the complex lesions, the all-of-the-above lesions, the ones I like to call the Cadillacs and the Lamborghinis of congenital defects. So again, here we have all of our alphabet soup. We'll talk about them one at a time. First one I want to talk about is transposition of the great arteries, sometimes called transposition of the great vessels. So instead of TGA, it might be TGV. So what happens is, remember I said at the very beginning, these are the only arteries in the body that have blue blood. These are only veins in the body that have red blood. Well, in utero, as they were developing, their aorta and their pulmonary artery got mixed up and didn't untwist the one time they were supposed to, and they ended up on the wrong side. Now, it doesn't sound like that big a deal till you start tracing the blood path through these defects. So we've got the blood coming back through the vena cava, going to the right atrium, this is the blue blood, going out the right ventricle, going out the aorta to the body, coming back through the vena cava, to the atriums, to the ventricle, and out to the body. So this side, things get bluer and bluer and bluer. Let's try the other side. So we have the blood coming back to the lungs from the left atrium to the left ventricle, blood going right back to the lungs again. So we have two potentially closed systems where they're going on their own little way. The only thing that's keeping this child alive, if they are completely closed systems without what it's showing here of an ASD of some kind, is the only place they're going to be able to move over the oxygenated blood to the deoxygenated side is here in the PDA. So what that means is the PDA is required to keep this child alive until they fix them. So what happens when the PDA closes? This kid will become dead. They won't survive. This is called a ductal dependent lesion. There are a few lesions. I already talked about one and didn't mention the fact that it was ductal dependent. Do you remember when we were talking about the tricuspid atresia? And I said that the only way that that kid was getting blood to his lungs was through his PDA. So once we hit the PDA and the PDA isn't working anymore, no blood is getting to the lungs, that kid is going to die if we don't keep them on prostaglandins and keep that PDA open. So transposition kids and right hypoplast, which is tricuspid atresia, both of them are considered ductal dependent lesions. So if there's no movement and the PDA shuts, one of the problems we're going to run into is cyanosis. There's increased blood flow to the right side, So congestive heart failure is a problem. The blood will continually back up, so you'll end up with your liver congested, full of fluid, right? So we've got another problem. So not only are the lungs having the pulmonary edema and the congestive failure, it's backing up even further. So now your liver is overflowed. Since no good perfusion is going on, tachycardia and tachypnea are going to happen. Clubbing will happen. Blue upper and pink lower. Does that kind of make sense? Well, it makes sense that we're going to have blue upper. They're thinking pink lower if some of these different shunts stay open that we're supposed to close at birth. We can give this kid all the oxygen we want. If that PDA doesn't stay open, there is no way the blood is getting back to the body. The red blood is going to get back to the body. So you can give them all the oxygen you want. It's not going to do you a bit of good. So preoperatively, we keep the prostaglandins going to keep that PDA open, get rid of their CHF, and then we can, in the pre-op period, go in there and make a hole between the atriums to be a backup for that PDA. When they do the surgery, though, they're going to do a switch. Now, if you notice where these lines are, when they do the switch, they cut above the valves. So that this is actually your aortic valve down here in the pulmonary artery area. This is your pulmonic valve over here by the left ventricle. So what this is telling us, the switches have only been done for about 20 years now. So these kids are just starting to get to adulthood. We don't know if once they're in adulthood, if that pulmonary valve is going to fail and they're going to have to come back in and get a different kind of valve put in there on the left side. Another part of a switch that is super important, and we didn't used to do switches until like the 90s, because what we found is that we did the switch and they all died. And the reason they died is, can you think of something that would come off of the aorta that if we didn't move it could kill a kid? It's not in this picture, so you may know it if you know your cardiac anatomy really well. Coming off of your aorta, so it's here right now, is your coronary arteries. Okay, they come off the aorta right at the root, they call it, right at the beginning. So when they do the switch, something they also have to move is they have to take the coronary arteries off the right, off of this part over here in the right ventricle and reimplant them over here. So they're coming off the new aorta over here in the left ventricle. And if you think about the fact that this surgery is done within the first week of life, when their heart's about the size of an olive, how big do you think those coronary arteries are? I'm saying about the size of a thread. So we've got a kid who's got vessels the size of a thread that we're reimplanting. So what do you think is going to happen if that kid's coronary artery is kinked? He's going to have an MI. Now, can an infant look at you and say, I feel like there's an elephant sitting on my chest? Of course not. Think about our usual indicators for an MI. They're usually EKG patterns, troponin and CKMBs, right? Well, we just chopped this kid's heart open. Do you think the troponin and the CKMBs are going to be elevated anyways? You betcha. So it is no longer a good indicator. So the only thing we truly have is monitoring ST segments. So these kids in the immediate post-op period must have their ST segments monitored to be sure that the surgeon didn't leave any kinks in their coronary arteries. Long term, as I said, we don't know what's going to happen to that valve. If they're going to have to come back in and have that valve replaced when they get older. The next one we're going to talk about is pulmonary venous return in the wrong place. Just as we can have the artery side get messed up, we can have the vein side get messed up, because the pulmonary veins are supposed to go into the left atrium. But if they decide to hang with all the other veins in the body, instead of the red blood going back to the left atrium, it's going to go somewhere else, which is what anomalous means. So the pulmonary venous return that should be coming back to the left atrium is now going elsewhere in some other veins in the body. So here is one version that the pulmonary veins have merged with the innominate vein, which is not a bad way to go because it's pretty darn close to the heart itself. It's going right next to and fusing with the superior vena cava. So if it's actually doing that, we've got a good chance. Now, when you're talking anomalous pulmonary venous return, we can either talk total, as in all the pulmonary veins are jacked up and go in the wrong place, or we can talk partial. What we see more of is total. So we call these kids total veins. So when we get a TAPVR, what we have to find out, and it's not us, it's the docs, either by sono or by cardiac cath, where are those pulmonary veins? Have they connected, as in this picture again, where they've connected with the innominate vein? Have they connected into the right atrium with the coronary sinus, which is where the coronary veins drain back into the body? Or is it infracardiac, which means it's below the heart? So here's one, and you can see here they're connected right here to the superior vena cava. So this is the supracardiac, above, outside of the cardiac, outside of the heart. So again, here you can see it, where they're connecting right back into the veins very close to the heart. Subcardiac is the ones where I said it drains into the right atrium in the coronary sinus with the other coronary veins. Again, not that bad a deal because it just means there's a lot more mixing, but the red blood is actually getting to the heart and getting out to the body somewhere where it needs to be. Where it gets bad is when it connects way down here at the ductus venosus near the liver. So with those kids, you end up having very pink feet and not such pink anywhere else. Another problem that you run into, especially with the total veins, the total anomalous pulmonary venous return, is that the veins, which there should be 4 of, may be 8, 10, 15 veins, and instead of being nice, big, and fat, they're tiny little threads. So what the surgeon has to do, if that's the problem, that they're small, multiple, and tiny little threads, is that they are going to have to open up all those tiny little veins and then sew them back together, merged into larger vessels. Very difficult. Again, very skilled surgeon is required. Here's another picture of the infradiaphragmatic. And here's a picture of partial, where some of the pulmonary veins are coming back to the atrium, some are not. These kids can actually be undiagnosed for years because enough of their blood is going where it belongs that they don't notice that there's a problem. These are the kids that they're going to identify the problem when they come into the hospital for something else, some other kind of surgery, some bad respiratory infection, and all of a sudden they go in and things aren't right, so they'll go and do an echo or a cath or something on them and identify that they've got this defect. Now, the signs and symptoms are going to depend on if it's partial or total. It's going to depend on where the veins are connected back to. Is it close to the heart or way down there by the liver? So all of the things that are listed here are very dependent on location. Or they always say location, location, location. All of these symptoms could be very minimal or they could be severe depending on the kid and where they're going. Then we have the really bad ones. So not only do they have total anomalous pulmonary venous return where none of the veins are connected to the left atrium, the veins are obstructed. Blood is not getting out. So the blood is not leaving the lungs. Everything is backing up. I have only seen a couple of these kids, and neither of them were diagnosed in utero because it was many years ago. They come out of the womb, they get born, and they look like death warmed over from the second they're born. They usually get transferred to a high acuity pediatric hospital within the first half hour of life because they realize he ain't right, he ain't ever going to be right, we got to get him out of here where they can fix him. Nothing helps. Prostaglandins don't help. Oxygen doesn't help. blood pressure medicines don't help. They just need to get them to the OR, put them on a heart-lung machine, and get them fixed. These kids don't usually do very well in the postoperative period either. They frequently will come out of the OR still connected to the heart-lung machine, now being labeled as ECMO. Okay, I think I kind of mentioned all of this. So the postoperative complications, again, are going to depend on if they're obstructed, if they're not, if they're supracardiac, if they're infracardiac. It's all about the location with these kids. Truncus arteriosus is another issue where the two arteries didn't separate. So instead of having an aorta and a pulmonary artery separate, they're together. Here's another version. Now in this one, they're at least separated except right at the end. In this one, you can see they're together all the way through. Only one valve that has to do the work of both sides. Again, this one's a bonus because they have two very differentiated, pulmonary artery and aorta are very separated except right at the end. So depending on how severe the truncus is going to depend on how symptomatic they are in the pre-op setting. It's going to depend on how much problems you have in the post-op setting and how much of a repair you're going to have to do. So I think this, and if you think about what are you going to see? CHF. Because if they can't get through, or if all the blood is mixing coming out this common valve, of course this is going to end up being an increased pulmonary blood flow kid, right? Because this is a low pressure side, so instead of all of it going back out like to the body, a lot more of it's going to go to the lungs. I think that pretty much talks about it. This defect is very commonly associated with DeGeorge. If you'll recall, we talked about that way back at the beginning. So with this, we've got to fix these kids right away. We're going to do that deep hypothermic circulatory arrest thing again. And we have to separate out the pulmonary artery from the aorta. Since there's only one valve, which side do you think is going to get that good valve? You guessed it, the left side where the high pressures are. The right side's going to get some sort of a homograph. So here we have a truncus after the treatment. After the surgical repair. So if you notice, there was the valve that you were born with, and it's going to be made into the aortic valve. The pulmonary arteries, we're going to put in some sort of a tissue or cloth, whatever it's going to take. We want this to be nice and wide, and because this piece probably didn't exist before, we're actually going to have to go in and create that. Again, a time where having a very skillful surgeon becomes very important. Postoperative complications, what did they cut into? They cut into the ventricle, so conduction issues are going to be a problem. They cut into the ventricle, so the ventricle function isn't going to be very good, so low cardiac output is a problem. They could have pulmonary stenosis residual because when they put that new piece of conduit in place, it's still not wide enough. They could have PAH issues because, again, we had all that increased pulmonary blood flow in the preoperative period. And that new valve that we said we turned it into the aortic valve, it might not be a real good one and they might have trouble with it. The last defect I'm going to talk about, even though there's numerous more after this, is what I really like to call the biggest, nastiest defect of them all. This is what we, in the land of cards, call the sacred cow. We very much respect our hypoplastic left heart syndrome kids. Because if you think about what your left ventricle does in your body, it's a little bit important. You really need to have one of those if you want to have a blood pressure, right? Because that's how the blood gets out to the body. So let's think about this kid when they're born. So the blood will come back into the right atrium. It'll go down to the right ventricle. We're doing good so far. Goes out through the pulmonary arteries to the lungs, comes back to the lungs, to the left atrium, and can't get any further. So what's going to happen? If it can't get further, it's going to back up. So if it backs up, where is it going to back up to? The low flow, no grow, as well as the high pressure to low pressure, it's going to hit that PDA, back up, and go out to the lungs that way. So how is it getting to the body? Well, the same kind of a thing. The pulmonary artery is right there, right? So it's going to go out to the body from the PDA outward. So we've got this kid, right atrium, right ventricle, pulmonary arteries, left atrium, backs back up to the pulmonary, through the pulmonary veins, back up into the lungs. So the only way it's getting to the body is through that PDA. So guess what happens if the PDA shuts? You know it. This is another one of those ductal dependent lesions. This is the only one left of all of our defects that we give the family this type of a choice. They can do, number one, take their child home, love him a lot. When the PDA closes, their child will die. The end. Number two, take him home with a stent in the PDA so it can't close, and they sit on the transplant list. Infant hearts are far and few between. They might be on that list for months upon months, and in the meantime, they're working with a body who's not getting good perfusion because you only have the right atrium, the right ventricle, I mean. We can do option 3, which is our traditional 3-surgery approach. Or number 4 is really just like number 3, only you do a little bit less aggressive surgery at the beginning, but they still need the other 2 surgeries. So 3 and 4 are very, very similar. So here you are at birth, and as you can see, we have a nice big right ventricle and a very scrawny left. And remember what we said about no flow, no grow. If the left ventricle is not getting blood out to the body, what is the aorta going to look like? Look how big the pulmonary artery is, and look how little the aorta is. Okay, here's an even better one. So you can see how not only is the left ventricle hypoplastic, so is the aorta, right? No flow, no grow. Even better one. So you can see the difference. So how are we going to get this kid fixed so he can live a life? Because we want to make him live, right? We don't want him to die. So we're going to have to figure things out. Well, over the years, many different surgeries were attempted, and it was finally Dr. Norwood who came up with a procedure that will keep the kid alive long enough to start giving him his repairs. Because what they tried to do is they tried to do a full repair at birth. It was too much change in pressure gradients, too much change in flow, too much surgery to the ventricles. The kids were dying. The mortality rate was huge. It wasn't until Norwood came up with his procedure that we figured that they were able to start making it. So let's talk about the Norwood. Preoperatively, I think you can figure those out from common sense, what you're going to see. So let's talk about this Norwood again. So when they take the kid into the OR for a Norwood, this will be done within the first week of life. The first thing they do is they give a kid a BT shunt. We need to give them a permanent PDA. So we're going to put a piece of graft between the subclavian artery and the pulmonary artery to get more blood flow to the lungs. The next thing we're going to do is make what they like to call a neo-aorta. They're going to sew the pulmonary artery and the aorta together. So in essence, what they're doing is they're making the kid into a truncus, right? Because isn't that what a truncus is? The aorta and the pulmonary artery are one vessel. And and then the last piece that they're going to do is the piece of tissue, the septal wall between the atriums is completely removed. So we have one big atrium. The left-right atrium becomes something they call a common atrium. So that's what they do with a Norwood. Now, if a Norwood is being done on a very tiny little baby, this BT shunt is so small that it will clot off pretty quickly before they probably won't even leave the hospital. So on kids like under 3.5 or under 3 kilos of weight, they will do this type of a shunt instead after Dr. Sano. So instead of doing a small graft between the subclavian and the pulmonary artery, they're doing a bigger graft between the pulmonary artery and the right ventricle So this one is usually a 2 to 3 centimeter graft. This one is a 4 to 6. Bigger hole, bigger hose. They're not going to clot. So you're thinking, I'm sure, well, if that one works so good, why don't we just do that one on everybody? And believe me, after Cyano first came out with this, that's exactly what we did. Everybody got a Cyano shunt because that way we didn't have to worry about the little tiny BT shunt clotting off. But what the problem is, look where they're sewing this Cyano shunt. It's going to the right ventricle. So we are now, when we do our next surgical procedure and we get rid of this shunt, we now have scar tissue here. We only have one ventricle. Do we really want to put scar tissue on the one ventricle if we don't need to? Of course not. So for that reason, we don't use these unless we have to. They come back in 4 to 6 months, maybe even a little earlier, for the second surgery. So in the second surgery, they keep that neo-aorta together. It's still going to stay. But they get rid of the BT or the Cyano shunt, whichever one they had, and they do that Glenn again, where the superior vena cava is sewed directly into the pulmonary artery. So some of the blood is going to go blue directly to the lungs. Some of the blood from the inferior vena cava is still going to do that full mixing thing in the common atriums before it goes out to the body. Then they're going to come back in 2 to 3 years, maybe even 4 years, for their third surgery, which is called a Fontan. The Fontan takes the inferior vena cava and also sews it directly to the pulmonary arteries. So what you see is that all the red blood is inside the heart and all the blue blood is outside of the heart. And that's where they're going to live for the rest of their life, with a Fontan. Little different ways they can do the Fontan, but pretty much what I told you is it. So a completely repaired hypoplastic left heart, all of the blue blood goes directly to the pulmonary artery, gets oxygenated, comes back into the common atrium, goes out the right ventricle to the aorta and out to the body, and that's it for these kids for the rest of their lives. They may come back in for an occasional valve fix, an occasional problem with perhaps the connections to the vena cavas, but this is what they will live with. This is their palliative surgery that they will live with for the rest of their lives. Different picture. I'm going to stop at this point. I'm not going to finish up with any of the other defects. They're here in case you should take care of one of those children. You have gotten more defects than you will ever need in this lecture, and if you go into your textbook, they do talk about some of these defects, but I think the big important thing is with them is to understand the different categories: the increased pulmonary blood flow, the decreased pulmonary blood flow, the obstructives, and the complex. And if you can understand the difference between those 4 different versions, I think you're in good standing. Thanks for listening. See you soon.